Thanks for the opportunity to talk about the health trends across communities in Minnesota project today. My name is Sam Patnoe. I'm an informatics programmer at HealthPartners Institute, and today I'm presenting on behalf of the Minnesota EHR Consortium, which led this work in partnership with Hennepin County, the Center for Community Health, and with funding from the Minnesota Department of Health. So first, I want to give some background on the Minnesota EHR Consortium. It was formed in March 2020 in response to COVID-19. It includes researchers, state agencies, and the 11 largest health systems in Minnesota. Some of those systems are shown here on the screen on the right. These systems cover all regions of the state and provide care to over 90% of Minnesota residents. The consortium uses a federated data model, and in 2022 began a coordinated adoption of the OMOP CDM across all the health systems. Health trends across communities in Minnesota, also called HTAC Minnesota, began in 2023 as the first project to fully leverage the OMOP CDM across the consortium, with the goal of building a comprehensive statewide dashboard that could support public health surveillance, inform community health assessments, and promote health equity across the state. The HTAC Minnesota dashboard was released earlier this year and made publicly available at the link shown here in March. The dashboard includes prevalence estimates for over 30 health conditions. In the next slide, I'll talk about what those conditions are, how they were defined and selected. The denominator for 2022, as shown here on this screen, was over 5.4 million people, roughly 93% of the estimated state population. That denominator includes patients who received care at any of the health systems in the consortium within the prior 3 years, and prevalence estimates on the dashboard represent patients who received a diagnosis for any of the given conditions in the prior 5 years. This example is showing prevalence for asthma. Here you'll see that the dashboard has data by race, ethnicity, age, and sex. By geography, you can look at the dashboard and find data at the state level, or you can filter by region, county, and then go all the way down to the census tract level. And that was made possible because each of the health systems in the consortium added a census tract field to their location table. This image here shows an example of hypertension prevalence for one census tract in Minneapolis. The teal bars on the right show the prevalence of hypertension for the selected census tract compared to the overall rates shown for across the whole state of Minnesota, shown in the light blue charts there. The dashboard has data for the years 2020 through 2023, and it's much more timely than typical health survey data as it's refreshed annually. 2024 data should be available on the dashboard as soon as March 2025. So the process for selecting and defining health conditions for the dashboard included 3 main steps. First, the Minnesota EHR Consortium worked with the Center for Community Health to identify and prioritize health conditions for the dashboard, following the criteria listed here. That process led to the selected health conditions listed here. There are 31 of them currently, and they fall under a bunch of different domains. My favorite domain is Other, that captures everything. And then finally, from those selected health conditions, the Minnesota EHR Consortium worked with analysts and subject matter experts across the consortium to develop standardized OMOP concept sets for each of those conditions. These are mostly mapped from ICD-10 diagnostic code sets and existing algorithms, and they include the SNOMED and ICD concept mappings. They also account for metadata across the consortium health systems. They're reviewed by clinicians for validity, and each condition is defined uniformly across all the health systems and centrally managed. So now that you've seen a preview of the dashboard and have a better understanding of how the conditions were defined and selected, I'm giving you a look under the hood to see the engine that kind of runs the whole thing and makes sure it goes smoothly. A central part of that engine are the red boxes you see here, representing each health system's OMOP common data model. 2 customizations that were made for the Minnesota EHR sites included adding a census tract column to the location table, which I mentioned earlier, and then creating an observation 2 table to store flags for external data, the external data flags, and deduplication. Deduplication was an important part of this project to avoid the overestimation of prevalence for conditions. So now I'm going to give you a closer look from the health system perspective to explain how that process works. So now we're zooming in on that last visual and now looking at the health system perspective. I'll show you how this process works. Hopefully the animations work as well. So the first step is that each system sends de-identified patient level file with deduplication information for their patient population to an encrypted data shelter using one-way encryption. From there, in the encrypted data shelter, patient-level files are deduplicated and linked to external data using privacy-preserving hashing functions. And here this external data is represented by this green box that's coming from state programs. From there, a matched, encrypted, deduplicated person-level file is returned to each health system, and that's used for populating the observation 2 table with deduplication and external flags. So how this works is that if a patient is seen at 2 or more health systems within the consortium, they'll only be counted at the one that has complete race data, the most blood pressure measurements in the last 12 or 36 months, and the most recent year of a diagnosis. From there, since all the systems are using OMOP CDM, a single set of R code for generating summary data is sent to all the systems. That's run and creates a summary data file for each health system, represented here by this blue box. And then from there, those summaries are combined centrally and aggregated into the data file that becomes the source for the Power BI dashboard. In conclusion, the HTAC Minnesota dashboard demonstrates how OMOP can facilitate sharing summary EHR data across an entire state to monitor community health. For more information, please visit me at poster 119 in the Garden State Room right after this. You can scan this QR code. I don't know if it works from this distance, but it's pretty big, so you can try. And there's tons of great information on this website. There's condition descriptions, a glossary of terms, and an FAQ section. So please check it out and come talk to me with any questions, concerns, or compliments at the poster session right after this. Thanks for your time.